Coming on to the first cause of jaundice in pregnancy. Cholestasis in pregnancy occurs in about 1.5 of all the pregnancies in the Indian population, and because of estrogen sensitivity effect, it exhibits a familial tendency. Recurrent in successive pregnancies, or if the woman is on OCPs, then the chances of cholestasis in further pregnancy also increase. It exhibits basically in the late second and third trimester, more common in older, multiparous and twin gestations. Malaise and itching is very important. Itching here, the pruritus is very typical. It would be without rash, and the woman would be complaining initially of itching and pruritus in the palms and the soles, which worsen in the evening hours, and there is no rash. So this could go in favor of cholestasis. Insomnia, anorexia, mild jaundice, weight loss, epigastric discomfort, and because of malabsorption of fat, steatorrhea and dark colored urine, she can come with oily, foul smelling stool she can complain of. In the lab findings, it is important we see the raised bile acids, which are more than 10 millimoles per liter, moderate elevation of ALT, 2 to 10 folds increase, exceptionally they will go up to 1000. Raised alkaline phosphatase up to 4 folds, but we have to keep in mind that this is also increased because of placental isoenzyme. Raised bilirubin, raised GGT in 1/3 of the patients. So the pathogenesis of poor fetal outcome in these patients is not clearly understood, but it is postulated that a higher concentration of bile acids may be toxic and lead to sudden development of fetal arrhythmias or vasospasm of the placental chorionic vessels. So spontaneous preterm delivery, intrapartum fetal bradycardia, distress and IUD is quite common in these. Meconium stained liquor, and the risk of SB is greatest if we continue with higher bile acids beyond 37 weeks. So hence it is very important we do a fetal surveillance, daily fetal kick count, biophysical profile, liver function test of the mother, bile acids and coagulation screening. UDCA we know is very promising and is the drug of choice. 10 to 15 milligrams per kg has to be given. It decreases the pruritus, it decreases bile acids, and it also normalizes the liver function test. Rifampicin and cholestyramine I have mentioned here, but we rarely use it because we know that cholestyramine is basically it's an acid chelating agent, and it though improves pruritus but may exhibit vitamin K deficiencies. That is why it is associated with increased intracranial hemorrhage in the baby. So tropical emollients, yes, we do prescribe because they are very safe. They are tropically used. Aqueous base of menthol can be used, calamine can be used, but they do not decrease the level of the bile acids. It's only they improve pruritus to some extent. Now the question arises, should women with obstetric cholestasis be offered elective early delivery? Early delivery at 37 plus 0 weeks gestation should be planned. If the cholestasis is very severe, a bile acid level is more than 100. Women should also be informed about the inability to predict SB if the pregnancy continues. So there has to be a lot of counseling between the doctor and the patient before we finally do any intervention. Postnatal period is again very important. We cannot just leave the patient like this. Monitor the biochemical resolution. It is a reversible type of hormonally influenced cholestasis, we all know. So there is a spontaneous regression of the symptoms within 2 to 3 weeks, and occasionally it can go up to 6 to 7 weeks, which otherwise also in the normal pregnancy also the liver function test take time to come back to the normal. So we have to withhold the investigations and blood reports till that period of time. Reoccurrence in future pregnancies is as high as 50%, so the patient has to be informed about it, and she has to be counseled of not taking OCPs because that aggravates cholestasis in future pregnancies.